So for those of you who aren't familiar with me, I am a gynecologist here in Central Illinois, and I've been in practice roughly 21 years. I am also a busy mom of 6 children, and like many of you, I was diagnosed with an MPN in 2011. I was diagnosed with polycythemia vera, and then it progressed to rather aggressively to myelofibrosis in the summer of 2020, and then I underwent a successful, thank God, stem cell transplant in November of 2020. So as you can see, I have a couple of really strong and passionate reasons for talking about this particular topic today. So my objectives, I would like to review the incidence of stem cell transplantation in women. I'm going to address the unique challenges women face during pre- and post-transplant experiences, and I will identify common post-transplant issues facing women and review the appropriate treatment options. And there'll be time at the end of my talk if anyone has questions. Just real quickly, I have nothing financially to disclose. I'd like to start off with some statistics, and these are from 2020, just happened to be the year that I had my transplant. So in 2020, roughly 22,000 people in the United States had a stem cell transplant. Roughly 13,000 of those were male and 9,000 were female. If we do a little deeper dive into those numbers, we see that 2% or 448 of all the transplants in the United States in 2020 were done for an MPN. So what is the link between gynecology and a stem cell transplant? Well, women who undergo a stem cell transplant, we do face unique gynecologic concerns, and many of those concerns are age dependent, whether the patient is of reproductive age or of menopausal age. The needs will vary. And the management of gynecologic complications in long-term survivors of stem cell transplants still remains an unmet need in our daily practice, and that's why I think it's an important topic to address. It is important for comprehensive and multidisciplinary follow-up with experienced clinicians who are familiar with the unique needs of transplant patients. So if we're going to start off, let's start with just the pre-transplant gynecologic care and what that means. So in the pre-transplant assessment, a gynecologic referral would allow us as a gynecologist to evaluate a woman's current gynecologic health, her current sexual health, and to begin planning what she may need in her peri and post-transplant care. So being a step ahead and planning ahead will definitely pay off. And in this pre-transplant care, it's important that we do a baseline gynecologic exam. And in this visit, it allows us to talk to our transplant patients about what they may face, not only during the transplant, but also afterwards. And I will touch base on these in a little bit as we get further into the talk. But the main things that I like to just mention ahead of time to patients are to just let them know that they very well may start to notice some menopausal symptoms after the transplant. There's the topic of general graft versus host disease, which is very important, and a lot of patients going into the transplant may not even be aware that this is a problem. And lastly, it's important to talk about fertility preservation in our young patients. So our patients who still desire the childbearing in the future, it's important to talk to them about whether or not it's appropriate for egg harvesting, or even ovarian cortex cryopreservation, which is now a new and exciting frontier. And so this is a topic that definitely does not and should not be overlooked. When we talk about what can happen to patients in the post-transplant state, I always like to make sure that patients are aware that conditioning regimens, especially total body irradiation, may result in up to a 90% risk of ovarian failure. And pregnancies thus after transplant are rare, with an incidence below 3%. Patients who are facing a transplant are generally advised to avoid pregnancy from the time of the pre-transplant evaluation through at least 2 years after the transplant, and maybe even longer, because there is the potential for relapse, as we all are aware. And in addition, there's the the situation in which a lot of us transplant patients may remain on transplant-related medications that potentially could cause birth defects. So in this pre-transplant appointment with your gynecologist, it is important to have a thorough history, including your menstrual history. So I always like to ask patients, are you still menstruating? Are your periods regular? Are your periods heavy? Is the patient currently in contraception? And will she need to continue that contraception through transplant and beyond? And then the other issue that's very, very important is to discuss with the patient the potential for really heavy periods, or what we call menorrhagia. And this may happen during the transplant when our platelets drop to very, very critically low levels. So if a patient has a history of really heavy periods before her transplant, talking to her about how we can get a handle on that before the transplant is going to definitely be very prudent. It's a good idea to have baseline hormone labs checked before the transplant. And we use those baseline labs after the transplant to compare her ovarian function, especially in women who are wanting to have future childbearing potential. It's good to have a baseline to look back on and see how their ovarian function may have changed because of the transplant. And then there are some conditions that can be exacerbated by immunosuppression. And those are primarily viral in origin. So herpes simplex, HPV virus, which can cause abnormal pap smears or cervical dysplasia, as well as genital warts. If a woman is a carrier of either one of those two viruses, it's important to know that ahead of time, as she may suffer some sequelae of those viruses after the transplant. It is important to do a breast and a pelvic exam prior to the transplant, because after transplantation, there is an increased risk of solid organ tumors. And so if there is an abnormality on a mammogram or a breast exam, or an abnormality on a pap smear or on a pelvic exam, you would want that worked up prior to transplantation. And any appropriate preventative screening could be obtained before the transplant: a mammogram, a pap smear with HPV testing, pregnancy testing if indicated, and testing for and treatment of sexually transmitted infections. So we definitely want to make sure that any sexually transmitted infections are taken care of and eradicated before heading into a transplant. So this slide is a very busy slide, and I understand that, but I put it in the talk mainly because I think it is a great overview of the gynecologic care that is needed at different stages of our transplant journey. So if we start at the left-hand side of the slide, you'll see all of the issues that are important to address before the transplant. What issues should be addressed during the hospital stay? How about the first 100 days after transplant? And then beyond, the long-term management of our gynecologic health. And the thing that made me laugh about this slide is if you look at the second column to the left, the column that talks about during inpatient stay, I laughed when I saw the avoid sexual intercourse while you're in the hospital column, because I was thinking to myself, there were many things that went through my mind in the 28 or 29 days that I was in the hospital for my transplant, but I can tell you honestly, it was not difficult to avoid sexual intercourse in the hospital. So it was, as we switch gears to post-transplant gynae care, I'd like to just stress the importance of having a close clinical follow-up with your gynecologist. So routine gynecologic assessment is important between 3 to 6 months post-transplant. And at that first visit, it's important that we, as gynecologists, screen for genital graft versus host disease. I will talk more about that shortly as the talk progresses. The other issues that are very important that need to be addressed at this 3 to 6 month time frame is the current need for contraception in our patients. And how is she doing from a menstrual cycle standpoint? Is she still cycling, or has she become menopausal prematurely because of the transplant regimen? And also, how is she doing from a sexual standpoint? Any routine health maintenance that was not obtained prior to the transplant should be obtained at this time. And this is a good time for us to sit down really and have a good talk, heart-to-heart talk with our patients about how they're doing with their need for hormone replacement therapy. Were they thrown into menopause prematurely, and do we need to have that discussion at this time? So speaking of menopause, premature menopause is almost inevitable in transplant patients who undergo high-dose chemotherapy combined with total body irradiation. And current guidelines suggest that the hormone levels in post-transplant patients be checked annually. And like I said before in the talk, when we have the levels that were drawing before the transplant, it's nice to have those as a baseline so that way we can compare her ovarian function over time. And women that are considering or want to preserve childbearing, it's important to talk to women about their fertility goals and have those levels checked afterwards, those hormone levels, so that way we can help her to discern what is going to be the most prudent course for her fertility at that point. Lastly, when we talk about menopausal symptoms, I just want to show the importance or the impact that the conditioning regimens can have on our hormonal status. So 90% of women who were premenopausal prior to the transplant will report hot flashes and night sweats, and half of us will report vaginal burniness and painful intercourse. So these are very, very significantly high numbers. Over half, 54%, will report menopause-related mood disturbance. And this can be anxiety or depression or irritability. And a lot of these mood disturbance will come naturally because of what we've been through just having had the transplant alone. But then when you stack on top of that menopause-related mood disturbance, it can definitely be overwhelming. Hormone replacement definitely should be considered for symptomatic women after they've had a transplant. However, it is advised that we wait at least 3 to 6 months after our transplant treatment stops to ensure patients are medically stable. And I'll talk more about this in the next slide or two. But I just want to make sure patients are not under the assumption that just because they've had a transplant and they're thrown into premature menopause, that they are not going to be a candidate for hormone replacement. So the route of administration of hormone replacement varies depending on each woman's needs. And so for many of you, you probably are already aware that we can replace hormones in a number of different ways. We can give hormones orally, we can give them transdermally, or we can deliver estrogen vaginally. And the route with which we do this really does depend on each patient's individual situation. If a patient has pretty significant skin GVHD because of the transplant, then obviously we are not going to choose a transdermal application of hormone replacement. And in contrast to that, if a woman has significant gut graft-versus-host disease, orally may not be the best way to add back her estrogen or her hormones because she may not absorb those well. So again, it really just takes that one-on-one discussion with your gynecologist to find the right way to add back hormones. For younger women and for the women that remain premenopausal after the transplant, it's always best to discuss whether or not using an oral contraceptive or a birth control pill may be indicated, not only for their birth control, but also if there needs to be some degree of hormone replacement. But always, we always consider the risk of thrombosis or clotting. And if that is, if a birth control pill or hormone replacement is necessary, I always advocate working very closely with the transplant physician or the transplant team to make sure that they are also on board with this decision. There are definitely contraindications to hormone replacement therapy, and those would include if a woman has a recurrent estrogen-sensitive tumor, or if she has an abnormal mammogram that needs to be worked up, then obviously she would not be a candidate for hormone replacement at that time. If our transplant patient has active liver disease, or if the risk of thrombosis is unacceptable in that patient, then obviously we're going to avoid hormones. And lastly, of course, if a patient prefers to avoid hormone replacement, we're going to honor that decision. But there are safe alternatives to hormone replacement therapy. And I have a very strong interest in integrative medicine, and I use a lot of herbal supplements in my patients. But having a very broad knowledge base of how over-the-counter products or herbal supplements may interact with transplant medications is very, very important. So again, keeping that line of communication open between the gynecologist and the transplant physician when it comes to using complementary or alternative approaches. Sexual function and sexual dysfunction should definitely be addressed with all women post-transplant. And so the last few years at this conference, I've talked about sexual dysfunction among MPN patients. But as we talk about sexual dysfunction among transplant patients, it is still a very, very valid topic that needs definitely open and honest communication. So options for vaginal dryness and painful intercourse should be discussed. And also it's really important when we're talking to our transplant patients to just, be present with them, talk with them, ask them, how are you doing in terms of your body image and your self-esteem? How is your libido? And a lot of our physical characteristics may change, obviously, as we go through a transplant. And so just making sure that women are doing okay and just dealing with all of that and how it pertains to their sexuality, that's so very important. And lastly, it's always important to stress the safe sexual practices, because obviously we don't want any of our immunocompromised transplant patients to necessarily incur a sexually transmitted infection. As we switch gears from menopause now to bone health, this is another very important topic that we do not want to lose sight of in our transplant patients. So observational data suggests bone loss after a transplant may occur in 75% of patients at the spine and almost 60% at the hip. So these are some staggering statistics. And it happened to me personally after my transplant. So I take this subject very seriously. And the causes of bone loss in our transplant patients are varied. And the causes include chemotherapy and radiation, radiotherapy, the use of steroids, and the repetitive use of steroids in transplant patients will definitely impact our bone health in a negative way. Obviously, because like I had mentioned, premature menopause is a very significant reality of transplant, the loss of hormones will definitely have a negative impact on our bone health. And lastly, the other two things that I think we cannot forget about is the inactivity or the nutritional factors that go along with having had a transplant. And so again, if there is significant gut GVHD and we're not absorbing our calcium or our minerals or our other minerals in a way as we, in a good enough way as we did before our transplant, then obviously our bones are going to be potentially vulnerable. So we have to keep those things in mind. It is important to screen patients approximately 1 year, 12 months post-transplant for bone loss using just a traditional DEXA scan. And current guidelines recommend that all transplant patients should be taking calcium and vitamin D, and it's important that our transplant patients undertake regular weight-bearing exercise. If I have a patient who is suffering from pretty significant menopausal symptoms, hot flashes and night sweats, and she also has bone loss, the first thing that I will recommend is that we consider hormone replacement therapy if she's a good candidate, because hormone replacement therapy will not only alleviate her menopausal symptoms, but it will also improve her bone health. When we look at the data, hormone replacement therapy can increase a patient's bone density approximately 3 to 8% per year, which is, in my opinion, very significant. And lastly, obviously, we're going to use appropriate osteoporosis medications when indicated. I now want to talk about a topic that I knew very little about, even as a gynecologist, before I personally underwent a stem cell transplant, and that's the topic of genital graft versus host disease. So the incidence of genital graft versus host disease varies from 35% at 1 year to 49% at 2 years post-transplant. So again, these numbers are significant, and these numbers may be underreported because patients may have a reluctance to discuss this topic. It may be embarrassing to them, or they may be fearful. And then also we have to remember that there may be a degree of the clinician not bringing this topic up in conversation with the patient. So genital graft versus host. Genital graft versus host can involve both the vaginal tissues and the external or vulvar tissues, the labia. And vulvar graft versus host occurs in about 25 to 50% of women undergoing a transplant, roughly 9 months post-transplant, but can occur much later. And the symptoms of genital graft versus host, there's a pretty significant overlap between these symptoms and the symptoms of menopause as it pertains to the genital tissues. So the symptoms include genital discomfort, itching, burning or paresthesia, pain, dryness, and painful intercourse. So mild genital graft versus host disease may show the following signs on exam. So the tissues may be red or swollen, or the tissues might be pale and thin, what we call atrophic. There may be fissuring or cracking in the tissue, and there also may be some ulcerations. And ultimately, the thing that we always want to try to avoid is scarring. So there can be pretty significant scarring in the vaginal canal, to where the vaginal canal can be completely obliterated if genital graft versus host is left untreated. So this is why that first exam, 3 to 6 months post-transplant, is so very important. So how do we manage genital graft versus host? Well, like I said, routine gynecologic exams, just so that way we as gynecologists can identify it early on and we can get treatment started. It's important to educate our patients about good genital skin care practices, and that means avoiding a lot of harsh soaps and irritants to the vaginal and vulvar tissues. I'm a huge proponent for topical treatments like vaginal estrogen when needed and vaginal moisturizers. And also we can use topical steroids to the vulvar tissue if needed. It may be an issue where we need to work in conjunction with the transplant physician to see if maybe the transplant patient who is suffering from genital graft versus host needs to be restarted on their immunosuppressive medication, or maybe that dose needs to be increased. And topical estrogen therapy should be started very early on after transplant in all patients. And the topical estrogen may not prevent genital graft versus host, but it can very well minimize the symptoms so that they are not a bother to the patient. And it can also minimize the concomitant menopausal symptoms as they pertain to the vulvar tissues as well. Occasionally, we will have patients use vaginal dilators if they're not able to have a regular sexual, if they cannot have sexual intercourse on a regular basis. And unfortunately, if the vaginal scarring becomes so severe, then surgery very well may be indicated. And lastly, as I get close to wrapping up here, I just want to reiterate the importance of breast and cervical cancer screening, because we do know that the risk of secondary solid tumors is increased following a stem cell transplant. And transplant patients are at an increased risk of breast cancer, especially transplant patients that had total body irradiation in their conditioning regimen. And those women that had TBI should have a mammogram and breast MRI by age 25 or 8 years after radiation exposure, and no later than age 40. And for all of our other patients, When we recommend and how often we recommend breast cancer screening will vary depending on each individual's past history, their family history, and what their breast cancer risk score is. So that's a shared decision-making process between you and your physician. With cervical cancer screening, about 40% of females will have an abnormal pap smear after a stem cell transplant. And unfortunately, 20% will have a high-grade lesion, whether that is a cervical abnormality, a vulvar abnormality, or a lesion surrounding the anogenital region. And the incidence of cervical cancer after stem cell transplant has been reported to be 13 times higher than the incidence in the general population. And the risk factors for this increased risk of cervical cancer definitely is related to long-term duration of immunosuppressant therapy as well as genital graft versus host. Also, obviously, we cannot overlook the impact that HPV or human papillomavirus has on these risks. So HPV is the most common sexually transmitted infection in the US. It is estimated that 14 million new infections of HPV occur annually. And HPV is the most common cause of cervical cancer. So we don't take human papillomavirus lightly, especially in our immunocompromised transplant patients, because transplant patients are at a risk of HPV that may have been latent or kind of dormant. It can reactivate, or they may be at risk of a new HPV infection. So for our transplant patients that are at risk, we may want to consider HPV vaccination 6 to 12 months post-transplant. And also it's very critical to remember that it is having a pap smear and an HPV test annually for transplant patients is paramount. Most of you probably are aware that we no longer do pap smears annually in our non-transplant patients. In just a routine patient, a normal pap smear and an HPV test is good for 5 years, but that's not the case in our transplant patients. Transplant patients need to have their pap smear and their HPV typing done annually. So in summary, I just want to leave you with the following things to remember. So the optimal care of the female stem cell transplant patient requires gynecologic care at several stages. And it is absolutely critical to have a very close collaboration between your gynecologist and your transplant physician, because that truly does improve outcomes. And the care trajectory includes fertility and fertility preservation, as well as the management of menopause and genital graft versus host disease. So thank you very much for the opportunity to speak.